When we're evaluating patients with low back pain, one of the first things we want to really look at is observation of their postural alignment. We'll talk a little bit in class about posture and the influence of pain. There's been really limited studies with how posture influences acute or chronic low back pain, but we just want to get a general sense of posture and how they're standing, how much weight they're putting on the limb. So first we want to take a look at the top down, so just kind of looking at the head position, the elevation of the shoulder. Typically handedness plays a role. Typically if the right hand dominant, the dominant side is typically lower. In our patient here, he's left hand dominant, so his left shoulder is going to slope down, be a little bit lower in response to the right. Again, I want to look at just a general idea, and I can use 2 fingers to kind of run down, just to kind of get a general idea of the orientation of the spine. And again, I'm looking at the presence of a kyphosis. The apex of the kyphosis should be at the level of T7. And then I'm looking at the arm windows. Arm windows, which is the width between the lateral trunk and the elbow, can give you an idea if the presence of a lateral shift. So if the patient had scoliosis or a lateral shift, you might notice an arm window that's a little bit wider on one side compared to the other. So just getting a sense of the arm windows, and then getting a sense of iliac crest height. So coming up on top of the iliac crest, getting a sense of height of the iliac crest. If one iliac crest is higher than the other, then you may think there could be a leg length discrepancy there, either apparent or anatomical. And then getting a look at foot position. So ideally, we want to look at greater trochanter height. Again, look at the popliteal creases and get a look at the foot from the rear foot. So ideally, I want to get a sense of how the patient stands normally to get an idea. And then what I might do is standardize the patient's alignment and foot placement by, Carter, I'm putting my foot in between. Place your foot close to my foot on either side. So just bring your feet in closer for me. Yeah, good. And then do a secondary postural alignment just based on a standardized position. But I want to get a sense of what the patient's comfortable postural position is. So our patient that comes in with low back pain, I've gone through my subjective and I want to know exactly where the patient's location is in terms of pain. Now I'm ready to start my active range of motion assessment. So active range of motion assessment, I'm looking at a couple things. I'm asking the patient to move through different planes of motion, frontal, sagittal, coronal planes of motion, looking for reproduction of the patient's comparable signs. So again, they're familiar symptoms. I also want to get a sense of where the patient's moving, how they're moving, and if they initiate movement well, and what's the quality of motion as they go through. So Carter, what I'm going to have you do is I'm going to have you back up just a little bit. So what I want you to do is, again, I'm looking for the patient's resting baseline of symptoms. So if they have a symptom out of 1 out of 10, and maybe it's isolated to the right low back, I'll tell him, okay, now I'm going to ask you to do some movements. If any of these movements reproduces your familiar symptoms, let me know. Okay. So what I'm going to do is I'm going to stand behind him and off to one side because I want to look at a couple of things. Go ahead and reach down towards the floor for me. Go as far as you can and back up. Did that reproduce any of I'm going to ask him if that reproduced any of his familiar symptoms. If it did, and he's clinically irritable, I may go ahead and stop that repetitive motion. If I've gotten my idea that he's got pain with that, I'll stop there. If he doesn't have pain with that, I may ask him to do repeated motions. Okay, Carter, what I want you to do is just do some repeated motions, forward bending, like you're going to touch your toes. So go ahead. And as he moves through, come back up and back up. And moves through, yeah. And as he's doing through these motions, I may ask him to do up to 5 or more, looking for any change in reproduction of symptoms. If after 5 to 7 repetitions, he doesn't have any symptoms with forward flexion, I'm gonna have you go ahead and go forward again. If the patient has full range of motion with no pain, I'm gonna apply overpressure. So the overpressure is application of the palm of my hand over the sacral base with my other hand at the thoracolumbar junction, and I'm applying kind of a spreading of force and a bowing of the spine. Any pain with that?
No.
Okay, and come back up. Okay, so as he's moving into forward flexion, I'm looking at a couple of things. As he goes forward, go ahead and go forward for me. I'm looking at, can he come back a little bit. Can he keep his knees straight? Bring your feet together a little bit more. Bring your feet together. Yeah. Go ahead and go forward. So when he was doing the active range of motion assessment, is he able to go forward? Does he get a little bit of a posterior shift of the pelvis with forward flexion? Is he able to keep his knees straight? Again, I'm looking for compensations of motion. Come back up. Because sometimes motion in the lumbar spine can appear normal, but if you're looking at other parts of the lower extremities, you can see that there's some flexibility issues there. All right, so then go ahead and put your hands on your hips for me. And then again, I'm standing behind the patient. Go ahead and lean back for me. Lean backward. Yep. Any pain with that?
No.
Okay, and come back up. And then just do some repeated motion for me. So just do a couple times. And again, I'm looking at the quality of his motion. Again, I should see an increase in the lumbar kyphosis or lordosis. An increase in lordosis. Any pain with that?
No.
Okay, and so if no pain, go ahead and do that one more time for me. If no pain, I'm going to apply some stabilization on the sacrum, and then apply a compression straight down. Any pain with that?
No.
Okay, come back up. All right, now I'm going to have you go into side bending. So again, just take your right hand, slide your right hand down your side for me. Yeah, good. Yeah, and come back. So you can see he's compensating there. So what I want you to do is just to let your hand slide down to about the level of the knee. Yeah, so you want to make sure that he stays in the frontal plane. And you should see a slight curvature of the spine as he goes into side bending. So come back up. Any pain with that?
No.
Okay, just do some repeated motions for me, nice and easy. And again, I'm looking for that nice C curve with the apex pointing towards the left. Any pain there?
No.
Okay, so again, with repeated testing, if there's no pain provocation, go ahead and come to the right again. Okay, I'm just going to stabilize his hip and apply pressure straight down. Good. Anything there?
No.
Okay, and then now go to the left for me. So, yeah, so again, he's kind of forward flexing at the hip a little bit, so I'm going to just correct him on that. So just come to the side, good, and back up. Any pain with that?
No.
Okay, and then come back to the left. And again, I'm looking for a smooth curvature of the lumbar spine with apex to the right, and come back up. Any pain with that?
No.
Go again. So after some repeated motions, if there's still no pain there, go ahead and go to the left again. And then I'm going to stabilize the pelvis and apply straight compression. Any pain there?
No.
Okay, come back up. Okay. Then I'm going to have him sit on the plinth. So go ahead and sit on the plinth for me. Okay. Then I'm going to have him go through rotation. So what I want you to do for me is just to sit back a little bit with your knees together. Yeah. So what I'm going to have you do is place your hands over your chest here, and then I'm going to have you rotate to the right. So again, I'm using my leg to kind of block his knee. Any pain with that?
No.
Okay, and then apply a little overpressure. Good. And then come to the left. Any pain with that?
No.
And again, I'm applying more pressure into the direction of rotation to get that firm infeel. Good. So I want to make sure with all of my overpressures and all those different planes of motion that I'm able to provide a little bit of overpressure to kind of maximally stress the tissue to see if we're looking for any comparable sign and trying to get a sense of I'm at the end of that tissue resistance if the clinical irritability allows. But again, that's active range of motion assessment of the lumbar spine.